Hello everyone, welcome back to the series of lectures in endocrinology. Today we'll be starting off with a very important and interesting topic which is often found to be difficult by many of the students. So that is the disorders of the parathyroid gland and calcium homeostasis. So let's begin. So before we move on to the disorders of the parathyroid gland, let us understand how this calcium ion is metabolized in the body. Okay? So about 99% of calcium in the body is stored where? It is stored in the bones. Okay? So about 99% of the calcium in the body is stored in the bones. Okay? So around 1000 to 2000 grams, that is around 1 to 2 kg is stored within the bones. Okay? And this calcium is in a flux with what? It is in flux with the extracellular calcium, with the ECF calcium. Okay, it's in a state of constant flux. So there is a constant flux between the ECF calcium and the bone calcium depending upon what is the need of the patient. Okay, so how much of calcium is removed from the bone to maintain it in the extracellular fluid? So around 1 to 2 grams of calcium is there in the extracellular fluid, which includes your blood, and about 1000 to 2000 gram is within your bone. So around 0.25 to 0.5 gram is in the flux state. Now, within the blood, what is the normal calcium levels? It is 8.5 to 10.5 milligram per deciliter. Okay, so out of which 50% is in the ionized form and 50% is in the bound form. Okay, so about 50% is in the ionized form and 50% is in the bound form. Ionized form basically refers to the free calcium, or the free calcium is your ionized calcium, and bound form where the calcium is bound to what? It is bound to albumin. Okay. So the largest storehouse of calcium in the body is in the bone. So how is this flux maintained between the extracellular compartment and the bone? So this is dependent upon this very important hormone, which is your parathormone. Okay. So we can derive that. What is the function of the parathormone? The parathormone is basically a hormone which is produced from the parathyroid gland. It acts on the bone and it basically increases the serum calcium levels. That means that it acts on the bone and it demineralizes the bone. So it causes demineralization. It causes demineralization of the bone and increases the serum or the plasma calcium levels. At the same time, it is responsible for excretion of phosphorus. It excretes phosphate and hence it decreases the serum phosphorus. Okay, so this is a very important and basic point about parathormone function that you have to remember. So the main function of parathormone is that it demineralizes the bone and it increases the serum calcium level and causes excretion of phosphate, so it decreases the serum phosphate level. Okay, so this is the first aspect of your calcium homeostasis, about how calcium is maintained in the extracellular fluid and in the bone and how parathyroid hormone acts. Now let us look at how dietary calcium is handled. So dietary calcium is absorbed predominantly from where? It is absorbed from the duodenum and the jejunum. So the site of absorption of dietary calcium is from the duodenum and the jejunum. Okay. So the intake is around 1 gram per day, let us say. Then the absorption is around 400 milligram per day. So only 40 to 50% of the dietary calcium that you take in is actually absorbed. So first point clear. Second, how is this absorption brought about? This absorption is brought about by means of an active transport. Active transport using certain ion channels. The ion channel in the intestine is TRPV6. So you have two types, TRPV6, TRPV5. V5 is in the kidney, V6 is in the intestine. So it is brought about by means of an active transport, TRPV6. Okay, and this is under the influence of another very important substance, which is your vitamin D. So this is your third point. Okay, so the third point about the absorption is that vitamin D helps in increasing the intestinal absorption of calcium. Yes, vitamin D helps in the intestinal absorption of calcium. So again, out of whatever 400 mg, whatever 1 gram is taken inside and 400 mg is absorbed. So out of which 0.25 to 0.5 gram again is in equivalence with the extracellular. Okay, so out of whatever is absorbed, around 0.25 to 0.5 gram is in a flux with the extracellular compartment. Okay, So there are 2 points about your calcium homeostasis which we have discussed. First is how your bone and extracellular, how does it interact, and now we have understood how your intestine and extracellular form, how does the calcium interact. Now let us understand the renal handling of calcium. So around 8 to 10 gram is the load of calcium that enters the kidney. So how much calcium enters the kidney? It is around 8 to 10 gram. Now once it enters the kidney, the calcium is reabsorbed in multiple sites. Normally you do not find calcium in the urine. Okay, so the calcium is reabsorbed at multiple sites. The highest amount of calcium is reabsorbed in the proximal convoluted tubule. About 65% is reabsorbed in the proximal convoluted tubule. Okay, then in the cortical thick ascending loop. So CTAL is cortical thick ascending limb. So in the cortical thick ascending limb, around 25% of calcium is absorbed. And this is under the influence of another very important molecule, which is your CASR. CASR stands for calcium sensing receptor. So what is the function of this CASR? So whenever there is an increase in the plasma or serum calcium, whenever there is an increase in the plasma or serum calcium, what happens? This CASR is activated and it senses that okay, calcium is high in the plasma. Then what will it do? It will cause excretion. It will cause excretion of calcium. That's why this CASR is present and it modulates the calcium absorption in your. So when this calcium levels in the blood is elevated, it causes stimulation of CASR. CASR senses it and it basically causes excretion of calcium, and this modulates the calcium reabsorption in your cortical thick ascending limb. Fine? Okay? Now, 5% of calcium is absorbed from the DCT, and this is again via an active transport via another ion channel, which is your TRPV5. TRPV6 we saw it in the intestine, TRPV5 in the kidney. And here both PTH and vitamin D increase or act at this level in the distal convoluted tubule, and both PTH and vitamin D increase the calcium absorption from the DCT. Okay, so this is under the influence of PTH and vitamin D. Fine. So this is about your basic points, very basics about your calcium homeostasis. So let us just recapitulate that again. So first point, the maximum storehouse of calcium is within the bone. About 99% is stored in the bone, and this is under the influence of PTH. What is the function of parath hormone? It increases the serum calcium and causes excretion of phosphorus. Okay, fine. Then in the blood, what are the normal calcium levels? It is about 8.5 to 10.5 mg per deciliter. 50% is ionized, 50% is bound to albumin. Now, dietary calcium is under the influence of vitamin D. Vitamin D causes increase in the amount of calcium that is absorbed, which is the most common site. It is the duodenum and the jejunum. And this is brought about by means of which channel? TRPV5. When it comes to renal handling, 65% is reabsorbed in the PC. So, in the cortical thick ascending limb of the loop of Henle, the CASR, which is your calcium sensing receptor, acts and it modulates the calcium reuptake. About 5% of calcium is reabsorbed from the DCT, and this is under the control of both PTH and vitamin D. Clear till here? Now let us look at what is PTH. Okay, so what is PTH? So PTH is basically comprising of 84 amino acids, and this is a hormone which is produced from the 4 parathyroid glands which are present behind the thyroid gland. So what is the function of PTH? It causes increased absorption from the intestine and the kidney. It causes increased absorption of what? Of calcium. It increases the serum calcium level by increasing the absorption from the intestine and kidney via vitamin D as well that we saw. Then it causes increased synthesis of vitamin D, so it indirectly increases the serum calcium levels. It causes dissolution of bone mineral and it causes excretion of phosphorus. So all of this we have seen. A very important practical point that we should be knowing is that continuous administration of PTH. So if this PTH is there continuously, right, then it causes osteoclast mediated bone resorption. This we know, just now we have seen. So if PTH is there continuously, it is going to cause resorption of bone and increase in serum calcium levels. But the catch point here is intermittent administration of PTH. intermittent administration of PTH. That means PTH is given like once a day, twice a day, it is given intermittently, once a week, so on and so forth. So you will have intermittent peaks in the PTH levels. Now this is paradoxically going to cause increased bone mass. This is a very, very important point. So when you give PTH intermittently, it is going to paradoxically cause an increased bone mass. It is going to increase your bone mass. So that is the reason why. What is the practical application of this? The practical application is that we give intermittent recombinant PTH in the treatment of osteoporosis, and this is nothing but your teriparatide. Okay, so if you get a doubt, teriparatide is also a synthetically available PTH. How is it used in the treatment of osteoporosis? It is used in the treatment of osteoporosis because intermittent PTH actually causes bone formation. Alright, fine. Now let us move on to this topic of hypercalcemia. Okay, so what is the normal calcium levels? Normal calcium levels are between 8.5 to 10.5 milligram per deciliter. Okay, normal calcium levels are between 8.5 to 10.5 milligram per deciliter, and those conditions where there is an increased calcium beyond 11 milligram per deciliter, that is your hypercalcemia, and let us look at the causes one by one. Okay, so first, PTH is the hormone which is responsible for increasing the serum calcium level. So conditions where the parath hormone is increased, so parathyroid related, let us see. So first is primary hyperparathyroidism. Primary hyperparathyroidism. This can be because of what? It can be because of a parathyroid adenoma, which is a benign tumor of the parathyroid gland. There can be increased PTH production, so increased calcium. Then multiple endocrine neoplasia. This we had already seen. In which men syndrome do you have hyperparathyroidism? You have it in your MEN1 syndrome. You have it in your MEN1 syndrome, where there is a genetic defect with which gene? Menin gene mutation. So you remember MEN1 3Ps, parathyroid, pituitary and pancreatic neuroendocrine tumors. So that is your parathyroid adenoma. Sometimes, rarely, you can have a parathyroid carcinoma, and all of these cause increase in PTH. Okay, so PTH mediated first we have seen. Second, lithium therapy. Now lithium is basically a drug which is used in the management of bipolar disorder. Lithium can also induce PTH and cause hyperparathyroidism, hypercalcemia. Then familial hypocalciuric hypercalcemia. So remember, this is a PTH mediated. This is a cause of PTH mediated hypercalcemia. So this is also called as FHH. Okay, familial hypocalciuric hypercalcemia. So where is the defect here? So this is because of loss of function. This is because of loss of function mutation of your calcium sensing receptor. Your calcium sensing receptor acts where? It acts on your CTAL, which is your cortical thick ascending limb of the loop of Henle, just now we have seen. So if there is a loss of function mutation of calcium sensing receptor, what is the function of CASR? Function of calcium sensing receptor is that it detects the blood levels of calcium and it causes excretion of calcium. So if the blood levels of calcium is high, it's not going to cause reabsorption, it's going to inhibit the reabsorption of calcium. Now there is a loss of function, CASR is not functioning. So irrespective of the blood calcium levels, your calcium is going to get reabsorbed. That is why you get familial hypercalcemia. And what is the urine finding? There will be hypocalciuria. Okay, this is the reason. This is your FHH. Clear? So this is about your first bucket, which is your parathyroid related causes for hypercalcemia. Second, let us the very important one and more common is your malignancy related. Okay, so what are the type of malignancies which cause hypercalcemia? We know that malignancies, most of them are associated with a specific syndrome which is called as your paraneoplastic syndromes. Amongst the most common metabolic paraneoplastic syndromes is your malignancy mediated hypercalcemia. And what is this due to and why is it segregated separately? Because this is not because of increased production of PTH, it is because of increased production of PTH-RP. What is PTH-RP? Parath hormone related peptide. Okay, it's because of increased production of PTH-RP or your parathormone related peptide. This parathormone related peptide also acts like parathormone and causes malignancy induced hypercalcemia. So what are the malignancies? Solid tumors like breast, which is most common, then solid tumors with lung, kidney, then hematologic malignancies, especially multiple myeloma and certain forms of lymphomas and leukemias. Okay, clear? So PTH-RP mediated. Then third, vitamin D related. Okay, so vitamin D basically increases the intestinal absorption as well as renal absorption of calcium. So when vitamin D is in excess, you can have hypercalcemia. So vitamin D intoxication. Then sarcoidosis and other granulomatous diseases and lymphoma. So what happens in your sarcoidosis and your other granulomatous conditions? So in sarcoidosis and other granulomatous condition, there is formation of a granuloma, right? There is formation of a granuloma. The granuloma comprises of multiple multinucleated giant cells, right? It comprises of giant cells. So in these conditions where there are multiple granulomas or in conditions like sarcoidosis, these granulomas in itself can produce 125 hydroxy vitamin D. Okay, this is nothing but your calcitriol. So the granuloma itself can start producing. That is the reason why you can have hypercalcemia here. So because of ectopic 125 hydroxy vitamin D production, because this granuloma can have 1-alpha hydroxylase activity, which is the enzyme which is required for production of 125 hydroxy vitamin D. Okay, so this is the reason why granulomatous diseases you can have hypercalcemia. Then 24 hydroxylase deficiency, there can be impaired metabolism of 125 hydroxy vitamin D. So this also can cause vitamin D excess, right? So this is about your vitamin D related causes for hypercalcemia. Then fourth one, high bone turnover diseases apart from hyperparathyroidism. So what are the other high bone turnover conditions? So this includes hyperthyroidism, immobilization and thiazide diuretics. Chronic use of thiazide diuretics is associated with what? It is associated with hypercalcemia. Then vitamin A intoxication and fat necrosis. All of these can cause hypercalcemia because of high bone turnover. Then lastly, we have those which are associated with renal failure, right? So in renal failure, what happens? In renal failure, we have already learned in our chapter of CKD. So when the GFR falls less than 20, when the GFR falls to less than 20, what happens? What happens? There is already some vitamin D deficiency. There is already some vitamin D deficiency. Okay, there is already some vitamin D deficiency because 1-alpha hydroxylase, which is required in your metabolic processes in your vitamin D activation, is not working because of your kidney problem. So there is some amount of hypocalcemia that is there in your initial stages. But as the renal failure worsens, this calcium is going to stimulate what? It is going to cause a feedback loop to your PTH and it is going to cause increased PTH levels. So there is going to be an finally increased PTH levels because of your chronic renal failure. This type of PTH production, which is not happening directly from the parathyroid gland, rather it is occurring due to some amount of vitamin D deficiency in your renal failure, is your secondary hyperparathyroidism. Okay, so in your secondary hyperparathyroidism, initially the calcium levels will be low. But over the course of time, what happens? This PTH is going to cause what? The PTH is in turn going to cause reabsorption of calcium. It is in turn going to cause reabsorption of calcium from the bones. It's going to act on the bone, cause demineralization of calcium and increase the serum calcium levels. Okay, fine. So in initial stages of renal failure, there will be hypocalcemia, which is going to stimulate your parathormone. This is your secondary hyperparathyroidism. In the later stages, continuous increased parathormone is going to cause demineralization, act on the bone and increase your calcium again. So serum calcium is in fact going to increase. Okay, so this is what happens in severe secondary hyperparathyroidism in your renal failure, right? Then aluminium intoxication and adynamic wound disease. If you go back to the lectures on chronic kidney disease, you would have seen that we had discussed about something called as dialysis dementia, which occurs due to aluminium intoxication in those days where the dialysis included aluminium compounds. So associated problem with this dialysis dementia is that this excess aluminum can worsen your adynamic bone disease and cause calcium absorption from the bone, or can cause demineralization from the bone. Another important syndrome, which is your milk alkali syndrome. So milk alkali syndrome basically occurs due to increased consumption of calcium carbonate, which was seen in the prior variants of antacids. So excessive consumption of calcium carbonate causing hypercalcemia. So in this condition, there is increased reabsorption of bicarbonate as well. It causes increased reabsorption of bicarbonate as well, because excessive calcium can cause dehydration, and in this dehydration process there is increased reabsorption of bicarbonate from the kidneys causing alkalosis. So this is the reason why it's called as milk alkali syndrome. So basic point is milk alkali syndrome is associated with increased consumption of antacids containing calcium carbonate. Okay, so I hope you have understood the etiologies for hypercalcemia clearly. So whenever we talk about the etiologies, you always classify the etiologies and speak about it. So we have PTH mediated primary hyperparathyroidism, PTH adenoma, MEN syndrome. PTH RP mediated is your malignancy related hypercalcemia. Then vitamin D related, vitamin D intoxication, ectopic production of vitamin D, for example your granulomatous diseases. Then high bone turnover states, hyperthyroidism, immobilization, thiazide diuretics. Then your renal failure related secondary hyperparathyroidism and milk alkali syndrome. Okay, so this is about the various etiologies for hypercalcemia. So now let's look at the clinical features. What are the clinical features of hypercalcemia? In the central nervous system, so a patient with hypercalcemia will present with what? They will present with confusion. They will present with a state similar to delirium. So they will be very delirious, they will be very confused, and in later stages they can also have stupor or coma. So basically altered mental status is a very important finding in hypercalcemia. Apart from that, you can have anorexia, vomiting, constipation with polyuria. Very, very important diagnostic clincher, constipation with polyuria. Then on the ECG you have short QT interval. So the QT interval is shortened in hypercalcemia. Okay. So this is about your acute hypercalcemia. In chronic hypercalcemia, depending upon how much is the degree of elevation of calcium, you can have calcification in your kidneys, you can have renal stones, you can have calcification of the vessels as well. So this has a very important clinical implication. For example, in your CKD patients, what we have taught and what we have been taught about is that long-term hyperparathyroidism has a negative impact on your cardiovascular system. That means that increased PTH is associated with an increased cardiovascular morbidity. In fact, it is associated with isolated left ventricular hypertrophy and dysfunction as well. Okay, this is what we have studied in CKD. And why is that so? One of the important causes is that it causes calcification of vessels, so it causes a increased risk of cardiovascular events. Okay, so this is clear about the symptoms of hypercalcemia. Now, let us look at one of the most important etiologies for hypercalcemia, which is your primary hyperparathyroidism. So primary hyperparathyroidism means what? The defect or the problem is at the level of your parathyroid glands. Okay, so the defect is at the level of the parathyroid glands. The most common cause for this is your parathyroid adenoma. Other causes we had already seen, your parathyroid carcinoma or your MEN1 syndrome. Right, so these are causes of primary hyperparathyroidism. Secondary hyperparathyroidism. So what is secondary hyperparathyroidism? The problem which we saw in your CKD. So what happens is that when the GFR falls to less than 20, the vitamin D is not functioning, it does not get activated. There is no formation of 1,25 hydroxyvitamin D because of deficiency or resistance to action of 1-alpha hydroxylase, right? So there is no vitamin D, so there is hypocalcemia, which stimulates your increased production of PTH. Over the course of time, this increased PTH chronically actually increases the serum calcium because it acts on the bone causes demineralization of the bone, and it increases the serum calcium. So there is increased PTH. So there is increased PTH and increased calcium. Apart from that, there is a very important molecule what we call as your FGF23. FGF23 is fibroblast growth factor 23. So this action, what is the action of FGF23? It is a phosphotonin. It is a phosphotonin and it causes decrease in the serum phosphate. It causes excretion of phosphate. So in your CKD patient, what happens is that this FGF23 is also not able to act. There is increased FGF23 levels, but there is resistance to FGF23 action. So finally what? Phosphate cannot be excreted, so there is increased phosphate as well. Okay, so this is about your secondary hyperparathyroidism. Tertiary hyperparathyroidism is also seen in CKD patients where over the course of time, if there is very severe hyperparathyroidism, the PTH becomes autonomous. There can be autonomous PTH production. There can be parathyroid hyperplasia because of this chronic stimulation of PTH. There can be parathyroid hyperplasia. PTH becomes autonomous. It becomes independent of the calcium levels. So here PTH is high, calcium is high, phosphorus is high. Okay. So this is about your secondary and tertiary hyperparathyroidism. Okay. Fine. Okay. So this is seen not tertiary hyperpara. So let us look at how calcium, phosphorus and PTH levels are different in your primary, secondary and tertiary hyperparathyroidism. So in your primary hyperparathyroidism, the PTH is causing the problem. It is produced from the parathyroid gland. So there is increased PTH. This increased PTH is going to cause increased serum levels of calcium and it causes excretion of phosphorus. So there is decreased phosphorus. In your secondary hyperparathyroidism, what happens? So in your secondary hyperparathyroidism, the initial stimulus is that there is a low calcium because of problem at the level of 1-alpha hydroxylase. There is no activated vitamin D and hence the calcium is low. Now this in turn is going to cause stimulation of your PTH. So your PTH will be elevated in your secondary hyperpara. And what happens to the phosphate levels? The phosphate levels will anyway be elevated because of your resistance to FGF23 action. Okay, fine. In your tertiary hyperparathyroidism, all of it is independent of the PTH action and hence all three will be elevated. There is autonomous functioning of your PTH and all three will be elevated in your tertiary hyperparathyroidism. Okay, so this is about your primary, secondary and tertiary hyperparathyroidism. Now let us look at the clinical features of primary hyperpara. So the first and the most important, which is your bone manifestation, is called as osteitis fibrosa cystic. So here, as the name suggests, there is a fibrous and cystic destruction of the bone because of continuous elevated PTH which causes demineralization. So the bone basically looks like this with lot of cystic demineralization. You can find this kind of a tumor-like appearance and it's also called as your Brown's tumor of the bone, which is seen with primary hyperparathyroidism. So the pathology will show increase in multinucleated osteoclasts in your house shape lacunae. So basically PTH is going to cause increased stimulation of osteoclasts, which basically cause increased resorption of the bone. It's predominantly the minerals. So if the mineral part of the bone is removed, what is left behind is nothing but your cells. So these osteoclasts or multinucleated osteoclasts in the lacunae is what gives rise to this appearance in your X-ray. Okay, and the marrow is replaced by fibrous tissue. The bone marrow is replaced by fibrous tissue. So can you see in the X-ray? Here you can see that there are some punched out lesions which are present in the radial aspect of your fingers. So this is also another finding of osteitis fibrosa cystic. So one is your brown tumor, another is this. So this is about the clinical feature of hyperparathyroidism predominantly in your bones. Apart from that, there will be other symptoms mainly because of your hypercalcemia. So this can be remembered with the help of this mnemonic: bones, groans, stones, psychiatric overtones. Okay. So bones we already know. Just now we have seen you can have osteitis fibrosa cystica or your high bone turnover disease. Then you can have groans. Why? Because they will have abdominal pain and other bony pains as well. So you can have groans because of that. You can have stones. You have calcium stones in the kidney. Then psychiatric overtones basically means hypercalcemia can cause a lot of confusion, delirium, so patient may look like he's having a psychiatric problem. So bones, groans, stones, psychiatric overtones. Okay. Apart from that, hypercalcemia can cause a lot of neuromuscular disturbances and it can cause proximal muscle weakness. It can cause proximal muscle weakness. Okay. So this is about the various clinical features. Now let us look at how will you diagnose and what are the various other diagnostic tests you want to use apart from your lab values to diagnose your primary hyperpara. So in your primary hyperpara, PTH will be elevated, calcium will be elevated, phosphorus will be decreased. This is clear. Then vitamin D, what happens? The vitamin D may be decreased or it may be normal. So primary hyperparathyroidism is because of hyperfunctioning of the parathyroid gland. There might be an adenoma, there may be hyperplasia as in men's syndromes. So the scans that you want to do, you can do a USD neck and you can see an adenoma if it is possible. Apart from that, a specific scan that we use is your technetium-99 CEST-MBBS scan. Technetium-99 CEST-MBBS scan is a very important scan which can be used to find out if the parathyroid abnormalities including adenoma is there or not. Apart from that, you can use 4D CT and this can help especially in imaging of the vasculature. This can help in the imaging of the vasculature. Okay, fine. Let us look at the treatment. So if this is a PTH adenoma, or hyperplasia, then you can do a minimally invasive parathyroidectomy. You remove the parathyroid gland, right? Then what are the indications for surgery, especially in a parathyroid adenoma? Not always you need to go ahead and do, but if you are doing, what are the indications? So asymptomatic patients, when do you want to do? In symptomatic patients, if they are not responding to medical therapy and initial treatment will be involving the treatment of hypercalcemia. But beyond that, you need definitive treatment is surgery. Okay. So in asymptomatic patients, do you want to go ahead and do the surgery? Yes. So when do you want to do? If the serum calcium level is more than 1 milligram per deciliter above normal. So if your serum calcium level is 10.5 is your cutoff, your serum calcium level is 11.512. And this is after you have brought down your hypercalcemia and still it is going up, causes parathyroid adenoma. So then you will have to do a surgery. Okay. Creatinine clearance less than 60. 24-hour urinary calcium more than 400. Presence of renal stones. And their bone mineral density, that is demineralization. So bone mineral density less than 2.5 at the lumbar or the hip, femoral neck or vertebral fracture is there. So at the lumbar spine, hip, femoral neck or vertebral fracture is present, then you have to go ahead and do a surgery. And in young patients age less than 50 years of age, you go ahead and resect the adenoma. What is the procedure that we perform? The procedure that we perform is your minimally invasive parathyroidectomy. Okay, fine. So how do you monitor the patient? So you have a patient with hyperparathyroidism. You have found out that the patient has an adenoma. You are doing a surgery. So how do you monitor? Intraoperatively. Okay. So how do you do? How do you know that you have removed your parathyroid gland only? So what you do is you check for the parathormone levels intraoperatively and after the surgery. After the surgery, you look for the parathormone levels again. The parathormone levels should ideally drop within 5 minutes of removal of the parathyroid gland. So the parathormone levels will drop precipitously within 5 minutes of removal of the parathyroid gland. So that is how you know that you are monitoring and you know that, okay, I have removed the parathyroid gland. Okay. Then you also look for your post-op calcium levels. The calcium levels are elevated in parathyroid, in your hyperparathyroidism, and it normalizes within 24 hours. So the calcium levels also return to normal within 24 hours. Because these parathyroid glands are very small, you need to do this monitoring. So to make sure that you are removing the parathyroid gland, you can do this kind of monitoring. Okay. So what are the side effects? Okay. What are the side effects of removal of your parathyroid gland? So when the parathyroid gland is removed, you can have hypocalcemia. Okay. Initially you will not have, you can have hypocalcemia. What are the mechanisms of hypocalcemia? We will be coming to that in a bit. Now, Is there a medical management available for primary hyperparathyroidism? Is there a medical management available for primary hyperparathyroidism? So yes, in patients who are old because of their frailty or because of the age factor, or they are not able to undergo surgery, then you can give them calcimimetics like cinacalcet. Calcimimetics like cinacalcet is given in the treatment of primary hyperpara. Okay. Now let us look at the post-op complications. The post-op complications are, there can be a transient hypocalcemia in the initial stages. Okay, most of the time they may or may not be symptomatic. So because your parathyroid gland is removed, there can be a transient hypocalcemia. Okay, so suddenly your PTH is dropping, there can be a transient hypocalcemia, and for this you may give IV calcium supplementation maybe for around 1 or 2 days. After that the body adjusts and the PTH returns back to normal. So there can be a transient hypocalcemia because of sudden withdrawal of PTH. Okay, fine. Now hypoparathyroidism, yes, if you have meddled with the parathyroid gland too much and you have done too much of a parathyroidectomy, no parathyroid tissue itself is available, all of it is removed, then you can have a secondary hypoparathyroidism after the surgery, and this can cause a permanent hypocalcemia. It causes decreased calcium and increased phosphorus. Okay, so PTH basically helps in decreasing the serum calcium and increasing the phosphorate. So if the PTH itself is not there, you have removed all of the parathyroid gland, then the calcium decreases and the phosphate increases. This is your hypoparathyroidism, which can occur as a complication of parathyroidectomy. So in these kind of patients, it is not transient, it may be permanent. So for these kind of patients, they have to be on lifelong calcium plus vitamin D supplementation. They may have to be on lifelong calcium plus vitamin D supplementation. So what type of vitamin D? We give activated vitamin D. We give activated vitamin D, which is your calcitriol. Calcitriol may have to be given. Another important complication is the presence of this, what we call as the hungry bone syndrome. Okay, so what is this hungry bone syndrome? Let us understand this. Now, you have primary hyperpara. You have primary hyperparathyroidism. So, what is the problem here? There is increased PTH. Now, this increased PTH is going to be acting on the bone, and it is going to cause demineralization. So, all the calcium is coming out of the bone. Okay, fine. The PTH levels is somewhere here. This is your PTH. Now, after surgery, what happens? You have done a surgery for treatment of your hyperparathyroidism and you have removed your parathyroid gland. Suddenly, your PTH comes to this level. Suddenly, there is a drop. The PTH suddenly comes down. So, when this PTH suddenly comes down, what happens? So, all this while the bone was giving out calcium. Now, what happens is that the bone is not used to this new, it is not accustomed to this new levels of parath hormone, and hence there is a sudden influx of calcium and phosphate into the bone. There is sudden influx of extra calcium and phosphate into the bone. Okay. So, because this bone was used to a certain state of metabolism when the PTH was high, suddenly the PTH has dropped after the surgery. It is not accustomed to this state of metabolism, so it takes back all the calcium and phosphate. And this is what we call as the hungry bone syndrome. So, in this hungry bone syndrome, you will have hypocalcemia. You will have hypocalcemia and hypophosphatemia. You will have hypocalcemia and hypophosphatemia because all of the calcium phosphate gets deposited into the bone. This is your hungry bone syndrome, which is seen post-operatively. So, how do you differentiate this hungry bone syndrome from your secondary hypopara? Right. So, is it that hypoparathyroidism is causing your low calcium, or is it your hungry bone syndrome? So, can you see a very, very important difference? This very, very important difference is that in hypopara, the calcium will be low, the phosphate will be high, PTH will be low. Here, the PTH level, it doesn't matter, it may be normal also. It is the problem with the bone's response to this surgery. So, here calcium and phosphate are low. This is how you differentiate. In hungry bone syndrome, both calcium and phosphorus are low. In hypoparathyroidism, phosphate will be elevated. Okay, clear? So this is about your post-op complications. Fine. So with this, we have understood what is primary hyperparathyroidism. Clear? Okay. Now let us move on to the management of hypercalcemia per se. We have looked at all of the causes for hypercalcemia. We have looked at primary hyperparathyroidism, what you do, surgery, post-op complications, etc. Now we will look at the management of hypercalcemia per se, right? So first step. So the management of hypercalcemia depends upon the degree of hypercalcemia and the rapidity with which it has occurred. So most of the time this is an acute hypercalcemia. Primary hyperparathyroidism may be chronic, right? It may be adenoma is slow growing, the symptoms are slow. But in conditions like where malignancy associated hypercalcemia or milk alkali syndrome, right? Milk alkali syndrome, vitamin A intoxication, or maybe your sarcoidosis. So these kind of conditions where the hypercalcemia is relatively acute, it does not go on for a very long time. So in these conditions, and depending upon the degree of severity of hypercalcemia, you have to treat the patient. Because this patient will be dehydrated, the patient can have AKI, predominantly pre-renal, because why? Hypercalcemia can cause polyuria and dehydration. That's why they can have pre-renal AKI. Calcium can cause tubular toxicity as well, so it can worsen the AKI. Apart from that, they can have a lot of confusion and altered mental status. So these symptoms can be reversed if you urgently treat your hypercalcemia. So what are the methods of treating? The first and the most important step is your hydration. Okay, so you will have to give around 2 to 4 liters of 0.9% NaCl. You hydrate the patient well. So what is the mechanism? So mechanism is that it causes increase in your urinary calcium excretion. It causes about 100 to 300 milligram per day loss of urinary calcium. So when you hydrate the patient, you can remove the calcium from the kidneys more usefully. Okay, and because this causes a pre-renal type of AKI, it will respond to fluids and your creatinine can also start coming down. Okay, so around 2 to 4 liters of NaCl per day has to be infused. Okay, you can give it as an infusion as well. Now, sometimes this hydration can be combined with a diuretic agent. Okay, combined with a diuretic agent like a loop diuretic, which is your Lasix, right? So this is what we call as forced diuresis. Okay, so you hydrate on one hand and you remove the water or diurese on other hand. This is quite paradoxical, but it is used. So what is the mechanism here? So the mechanism here is that hydration will help in increasing the urinary calcium excretion, but we have to ensure that it is not reabsorbed again. So this prevents the reabsorption of calcium. So this is about your forced diuresis. Then the only disadvantage, what are the disadvantages of your this kind of a treatment with hydration and diuresis? You have to be very careful in your patients with congestive cardiac failure or post-MI patients where the cardiac output is low, because if the cardiac output is low, they cannot manage this high fluid load that we are giving. We are giving so much of infusion, they can go into fluid overload. So that's why you have to monitor the patient carefully, monitor the urine output, look if they are getting breathless, they may complain of orthopnea because there can be pulmonary edema, accumulation of fluid in the lungs, JVP can get elevated. So all of these you have to look or watch out for. Okay, most of the time patients are recumbent, and in recumbent patients you will not get pedal edema, you will get where? You will have to check for sacral edema for volume overload. That's a very important practical point when you evaluate or examine the patient. Okay, so this is your first method of management for hypercalcemia, which is hydration. Second group is your drugs which we use for hypercalcemia, which is your bisphosphonates. What are the example of bisphosphonates? We have zolendronate, alendronate, alendronate. Okay, so this has an action onset of about 1 to 2 days and duration for about 2 to 3 weeks. Okay, it takes 1 to 2 days to start, but its duration is much longer, right? So bisphosphonates are going to decrease the serum calcium level, and it basically helps in moving the calcium back into your bone stores. Okay, so that is how you use bisphosphonates. So bisphosphonate does not cause a rapid decline in your serum calcium because it has an onset of around 1 to 2 days, but it has a longer duration of action. So this is mechanism of action is it inhibits bone resorption. Okay. So what are the side effects of bisphosphonates? Bisphosphonates can cause hypocalcemia, but not always, especially in this condition. For treatment of hypercalcemia, it's okay. Okay. Bisphosphonate can cause osteonecrosis of jaw. Bisphosphonates can cause osteonecrosis of jaw. Bisphosphonates have a lot of gastric side effects and hence you should be careful. This is predominantly for your oral preparation. For your IV, it is okay. The third drug that we use is your calcitonin. Okay. So the advantage of calcitonin is that it can be used in your cases of acute hypercalcemia because it has an onset of within few hours. So it can be used in cases of acute hypercalcemia because its onset is within few hours, but its duration is 1 to 2 days and it's given as 2 to 8 units per kg subcutaneous. The disadvantage of calcitonin is that it undergoes calciphylaxis. Calciphylaxis is basically a phenomenon where within 2 to 3 days of giving a particular drug, its action draws away. So the higher the dose that is given, the more amount of drug that is given to a patient, then the effect wears off. So it undergoes calciphylaxis, so it cannot be given for more than 2 to 3 days. It cannot be used for more than 3 days because it undergoes calciphylaxis. So beyond 3 days, the effect of the drug wears off. Then denosumab. Okay. So denosumab is basically a drug which acts against anti-rank L receptor. This rank ligand is basically present on the osteoclast and causes bone resorption. Denosumab acts against it. The duration is that it is more than 3 weeks, so it's very advantageous for maintaining your calcium levels for 3 weeks at least. Before you find out the cause, you're evaluating, treat them, it has a longer duration of action. So predominantly its use is in malignancy associated hypercalcemias because in malignancy associated hypercalcemia, the calcium levels can be high for a long time. So you need a longer acting agent. Then glucocorticoids. Next group of drugs is your glucocorticoids. This also has acute onset. So it has a fairly relatively faster onset. So it can be used in acute hypercalcemia and it has a longer duration of action. So this increases the urinary calcium and decreases the absorption of calcium as well. It increases the urinary calcium excretion and decreases the calcium absorption. So where do we use these glucocorticoids? They are very advantageous in your autoimmune conditions like sarcoidosis because they help in the treatment of the disorder as well. They can be used in certain malignancies, especially your lymphomas. But solid organ tumors, we do not really use glucocorticoids in the management of hypercalcemia. Now, you have done hydration, you have given calcitonin, you have tried all of these drugs, but there has been no improvement at all and the calcium continues to be high, patient continues to be delirious, there is AKI, then the final treatment is with your hemodialysis. So, if you have to do an urgent treatment where your medical management is not sufficing, then you have to do a hemodialysis and remove the calcium. Clear? So, this is about your hypercalcemia. So, now that we have learned about hypercalcemia, we will be moving on to the other end of the spectrum, which is your hypocalcemia. Okay. So, let us look at the causes for hypocalcemia. So, transient hypocalcemia. Where do you find transient hypocalcemia? It is seen in sepsis, burns and extensive blood transfusion. When you do large volumes of blood transfusion, what are you infusing along with the blood? You infuse citrate. This citrate will combine with calcium and it will form calcium citrate and thereby it will decrease the serum calcium levels. Then metabolic alkalosis is going to promote increased calcium binding to albumin, thereby decreasing the ionized calcium levels. Okay. So metabolic alkalosis is going to increase the calcium binding to albumin, thereby decreasing the ionized calcium levels. Then we have medications like heparin and glucagon, and acute pancreatitis can also cause hypocalcemia because acute pancreatitis there is lot of saponification of fat and these free fatty acids can combine with calcium and decrease the serum calcium levels. So this is about hypocalcemia etiologies, predominantly your acquired causes for hypocalcemia. Then we have certain genetic causes as well, predominantly your hypoparathyroidism. Now we will be looking at a different way of classification for the etiologies of hypocalcemia. So etiologies of hypocalcemia can be classified as PTH absent. So the first mechanism is PTH is absent. So whenever there is a decreased PTH, PTH is responsible for reabsorption of calcium, excretion of phosphorus. So decreased PTH, there will be decreased calcium and increased serum phosphate. Okay, fine. So if PTH is absent in your hereditary forms of hypoparathyroidism or acquired forms of hypoparathyroidism, and another very important element which is associated with hypocalcemia is your magnesium. Magnesium deficiency can also cause hypocalcemia. Then PTH is ineffective. So there is PTH, it's not that PTH is not being produced, but the action of PTH is not happening. There is resistance to PTH action. So this resistance to PTH action is seen in which all conditions? CKD. In CKD, what happens is that active vitamin D will not be present because in CKD, 1-alpha hydroxylase enzyme is not present. 1-alpha hydroxylase is responsible for conversion of 25-hydroxy vitamin D to 1,25-dihydroxy vitamin D. Right? So this is your activated vitamin D. And this is present where? It's present in the kidney. So deficiency of 1-alpha hydroxylase in CKD, there is no active vitamin D, and this can cause hypoparathyroidism or it can cause hypocalcemia. Defective metabolism of vitamin D. So abnormal metabolism of vitamin D can occur with anticonvulsant therapy. Okay, then vitamin D dependent rickets or your VDDR type 1. Here you have resistance to the action of vitamin D. Then intestinal malabsorption, again this is vitamin D deficiency, and VDDR type 2 also there is a resistance to the action of vitamin D. So the next most important cause is your pseudo hypoparathyroidism. So here you have signs and symptoms of hypopara. That means your calcium is low, phosphorus is high. Okay, calcium is low, phosphorus is high. So what will you expect? You expect what? PTH will be low, but here the PTH is high. Okay, PTH is high in pseudo hypoparathyroidism. Why? Because there is resistance to action of PTH. So PTH action is not happening. So your signs and symptoms are like hypopara, but your PTH is elevated. This is your pseudo hypoparathyroidism. Fine. Then the next mechanism is that the PTH is overwhelmed because of other conditions. So severe hypophosphatemia. Then tumor lysis syndrome. What happens? In tumor lysis syndrome, there is lot of tumor cells which are getting broken out. Okay, there are a lot of tumor cells which are getting broken out, and what happens is that the phosphate, which is predominantly intracellular, comes out and there is increased phosphorus. This increased phosphorus is going to stimulate your parath hormone to cause excretion. Because that is a normal function of parath hormone. But the parath hormone becomes overwhelmed and it cannot act further. In these conditions, there will be hypocalcemia as a result of this. This PTH cannot act. It becomes overwhelmed and hence the PTH becomes low. It cannot act any further and it causes hypocalcemia in your tumor lysis syndrome. Similarly with rhabdomyolysis and osteoid fibrosis cystica after parathyroidectomy, right? That we saw, like your hungry bone syndrome. So this is one of the causes. This is nothing but your hungry bone syndrome. So these are basically examples or causes for hypocalcemia. So hypocalcemia can be because of a PTH dependent cause where you have hypoparathyroidism. Then it can be because PTH is ineffective. The PTH is not able to act at its receptors. So this can be because of vitamin D deficiency, VDDR, where there is vitamin D dependent rickets or vitamin D resistance, then pseudo hypoparathyroidism and CKD. And PTH is overwhelmed. It cannot happen when conditions where there is severe hyperphosphatemia, especially for example tumor lysis syndrome, and other one is your hungry bone syndrome. In your hungry bone syndrome, the phosphorus levels will be low. But here also there is hypocalcemia because there is deposition of calcium and phosphate into the bone. Okay, so the etiology is clear. Now let us look at the clinical features of hypocalcemia. So how does hypocalcemia present? So in acute phases, if there is an acute drop in the serum calcium levels, it can result in carpopedal spasm, which is called as your Trosser's sign. So what you do here is you tie a BP cuff. What you do here is you tie a BP cuff and you inflate it to about 10 millimeters or 8 millimeters of mercury above the normal blood pressure. Okay. So when you give a suprasystolic blood pressure, what happens is that normally there will be no response, but the hand becomes like this. Okay. So it goes into a spasm, and this is what we call as the carpopedal spasm or the Trosser's sign, which is seen in hypocalcemia. Then we have another sign which is called as your Chvostek's sign. So in this, what do you do? Okay, so in this, basically you are demonstrating the hyperexcitability of the peripheral nerves, especially your facial nerve. Okay, so what you do is you do a gentle tap here. You do a gentle tap over the facial nerve, especially in the maxillary or the mandibular region, right? So when you do a gentle tap, there will be a sudden twitch. Okay, so there will be a sudden twitch, right? So this is what we call as your Chvostek's sign, which is also seen in hypocalcemia. So Trosser's sign and Chvostek's sign. Chronic hypocalcemia, how is it going to present? Chronic hypocalcemia can have neuromuscular manifestations. It can cause muscle spasms, laryngeal spasms. There is an increased risk of seizures and even respiratory arrest. So chronic or very severe hypocalcemia can cause muscle spasms, laryngeal spasm, convulsions and respiratory arrest. Apart from that, there can be symptoms of raised ICP. So raised intracranial pressure will present with headache, vomiting, seizures, papilledema. So there will be headache, vomiting, seizures and papilledema. Apart from that, hypocalcemia predisposes to arrhythmias. And what will you see on the ECG in a patient with hypocalcemia? You will find prolonged QT interval. So in the ECG in a patient with hypocalcemia, you are going to find long QT interval. Okay, so this is about the different clinical features. Now let us move on to the most important of the causes for hypocalcemia, which is your hypoparathyroidism. So hypoparathyroidism can be due to hereditary as well as acquired causes. Okay, fine. So how are these two different in their clinical manifestations? So how is hereditary hypoparathyroidism different from acquired causes of hypoparathyroidism? Hereditary hypoparathyroidism has a more gradual onset, whereas acquired is most often post-surgery or post-radiotherapy or due to infiltrative conditions like hemochromatosis, amyloidosis and so on and so forth. So they have a more acute onset, especially a post-surgical can be acute to subacute, but hereditary conditions are more chronic, they are more insidious. Then hereditary conditions can be associated with a lot of developmental defects, and you can find basal ganglia calcification, and this basal ganglia calcification will result in extrapyramidal symptoms like tremors. Okay, you can have tremors, you can have rigidity, you can have bradykinesia. All of these features which you see in Parkinson's disease, all of these can be seen here because of basal ganglia calcification. So this is seen in your hereditary causes for hypopara. In your acquired causes for hypopara, you will not have all this. Okay. Then you can have alopecia, you can have candidiasis. Where is candida seen? Your chronic mucocutaneous candidiasis is seen where? It is seen in your APS1, your autoimmune polyendocrine syndrome type 1. Okay. So this is about how both hereditary and acquired causes are different from one another. But papilledema, raised ICP, cataracts are all features which are common to both hereditary and acquired causes for hypoparathyroidism. Okay. Now let us look at the genetic causes. Okay. So the genetic causes are: one, you have your Dye-George syndrome. In your Dye-George syndrome, there is a catch22 mutation. There is a mutation of your 22nd chromosome. It's called as your catch22 deletion. So there can be various congenital defects, cardiovascular defects and facial defects. You have congenital defects, cardiovascular defects, especially for example your VSDs, ASDs, and you have your facial defects. Then your second one is your autoimmune polyendocrine syndrome, especially your APS type 1, which is a cause for hypoparathyroidism. Then Kearns-Sarre syndrome is basically another inherited defect. So then you have your Kearns-Sarre syndrome. So Kearns-Sarre syndrome, what happens? There is a problem in your mitochondrial metabolism, you can have cerebellar ataxia, you can have retinopathy, you can have cardiac conduction abnormalities as well. Then Melas syndrome stands for mitochondrial encephalopathy, lactic acidosis and stroke-like episodes. So these are all examples of some of the syndromes which are associated with hypopara. Then PTH mutations, these are inherited in an X-linked recessive pattern. So there can be mutations in the PTH which can result in hypopara. Then there can be mutations with CASR. Okay, so the type of mutation that you have here is an autosomal dominant hypercalciuric hypocalcemia. Autosomal dominant hypercalciuric hypocalcemia, which is seen due to gain of function mutation of CASR. Okay, so we had seen the exact opposite of this, which is your FHH. FHH is familial hypocalciuric hypercalcemia. Right? So here you have a loss of function mutation of CASR. So here, because there is a gain of function mutation of your calcium sensing receptor, this is going to basically cause increased excretion of calcium from the urine irrespective of what the blood calcium levels are. So there is hypercalciuria and hypocalcemia. So this is one of the other genetic causes for hypoparathyroidism. Okay. So we have Digeorge syndrome, APS, Kearns-Sayre, Melas and your ADHH. So these are all causes for your hypoparathyroidism, predominantly genetic causes. Okay. So how do you treat this? So the treatment will predominantly involve your calcium, vitamin D supplementation, especially your activated vitamin D, which is your calcitriol. Apart from this, you can give synthetic parathormone replacement. The newest update as per the Harrison's 22nd edition is the new drug, which is your palopeg-teriparatide, which is a synthetic parathormone which can be given for hypoparathyroidism as a replacement. Synthetic parathormone, palopeg-teriparatide. Okay, so now let us move on to another very important genetic defect, which is your pseudo-hypoparathyroidism. Okay, so this is basically a very complex topic, but I've tried to simplify it with certain very important key features, and you will be able to understand these concepts better. So pseudo-hypoparathyroidism, as the name suggests, what are the key clinical features? As the name suggests, pseudo-hypoparathyroidism means what? There are clinical features of hypopara. That means what? There will be hypocalcemia. Hypoparathyroidism causes hypocalcemia. Okay, and there will be increased serum phosphate. There will be decreased calcium, increased phosphorus. So you are expecting that the PTH levels will be low, but this is a pseudo cause. That means that the PTH is actually not low, the PTH is high. This is a pseudo cause. That means that the PTH is actually not low, PTH is high, because the PTH is not able to act on its receptors. So in pseudo hypoparathyroidism, you have all the clinical features of hypoparathyroidism. You will have hypocalcemia, increased serum phosphate, decreased vitamin D action, but the PTH levels are high because of PTH resistance. So this has to be very clear. So you should not be thinking why PTH levels are elevated means the calcium should be high, right? No, because PTH is not able to act on its receptor, the PTH levels are high. But because the PTH is not able to act, then you will not have your PTH action. So calcium is low, phosphorus is high. Then all of the patients or most of the patients with pseudo hypoparathyroidism have this kind of a specific skeletal abnormality that we call as Albright hereditary osteodystrophy, or the AHO phenotype. Albright hereditary osteodystrophy, or your AHO phenotype. So what is this AHO phenotype? So this AHO phenotype basically comprises of these. So a patient with obesity, round face, skeletal abnormalities like brachydactyly. can you see that the fourth metacarpal is short? Short fourth metacarpal, short fourth metatarsal, and you can have some degree of mental retardation as well. So, a characteristic feature if you have to remember about pseudo-hypoparathyroidism is the presence of this skeletal abnormality that we call as Albright hereditary osteodystrophy. And all in all, there is increased serum PTH because of resistance to PTH action. Okay, so this is about what are the key clinical features that you have to remember about pseudo-hypoparathyroidism. So what is the reason for this pseudo-hypopara? So there is a genetic defect in the GNAS gene which is present on chromosome number 20. Where else had we seen this? We had seen this in McCune-Albright syndrome. We had seen this under your Meon syndromes, right? McCune-Albright. Okay, so this codes for your G protein alpha subunit. So there is a mutation in that gene, your G protein alpha subunit. Okay, fine. Now, pseudo-hypoparathyroidism is classified on the basis of what? Pseudo-hypoparathyroidism is classified into pseudo-hypoparathyroidism type 1, pseudo-hypoparathyroidism type 2. Type 1 is further classified into two types as 1A and 1B. And you have another condition which is your PPHP, which is your pseudo-hypopara. Okay. So, pseudo-hypoparathyroidism is classified as PHP 1, 2 and you have your pseudo-hypopara. 1 is classified as 1A and 1B. So, what is the basis for this classification? So, the basis for the classification is based on 2 points. The first and the most important point is whether your Albright hereditary osteodystrophy phenotype is present or not. There can be variants of pseudo-hypopara where you do not have this Albright hereditary osteodystrophy. So, whether this is present or not. Second, what is the function of PTH? PTH acts on the kidney and causes increased urinary excretion of phosphate. Correct? So, PTH acts on the kidney and causes increased urinary excretion of phosphate. So, what we should be expecting is that we look for the biochemical evidence. We look for the biochemical evidence or the urinary response of PTH. Urinary response of PTH in the form of what? Increased phosphate excretion or increased cyclic adenosine monophosphate excretion. So, increased CAMP or increased phosphorus in the urine indicates that the PTH is acting on the kidney and it is all functioning normally. But if there is a resistance to the action of PTH, will there be urinary phosphate or urinary CAMP? No. The urinary response of phosphate or CAMP to PTH will be absent. So, in certain variants of pseudo-hypopara, you will have this biochemical issue. In certain variants, you may not have that as well. So, what is the reason for these differences that we will be looking at? But you should be understanding that in pseudo-hypoparathyroidism, it is classified into the various types based on these two major things, whether Albright hereditary osteodystrophy phenotype is there or not and whether your urinary response to PTH of phosphate is there or not. Okay. So, first we will focus on your pseudo-hypoparathyroidism type 1 only. Okay, so just look at the left half of the table, pseudo-hypoparathyroidism type 1. Fine. So, first let us look at the biochemical parameters. Fine. Type 1, hypocalcemia, yes or no? Yes, in type 1 you will have hypocalcemia. Both of them will have hypocalcemia. Correct? Okay. Why? Because there is hypopara. PTH is not able to act, so there is hypopara. So, hypocalcemia, hyperphosphatemia, increased serum phosphate. Agreed. Serum PTH will be high or low? Yes, there is a resistance to action of PTH, so PTH will be high. Till here clear. Then, urinary response of phosphate or CAMP to PTH, will it be present? No, because PTH is not able to act on the distal convoluted tubule of the kidney. It is not able to cause phosphate excretion. So, urinary response, if you check the urine phosphate, it will not be there. So, it is absent. Will you have your Albright hereditary osteodystrophy? Yes, you will have your Albright hereditary osteodystrophy. Then what is the difference between your pseudo-hypoparathyroidism type 1A and type 1B? So, some features of AHO will be there in your type 1B, not all features of AHO. Okay. So, is there a GS alpha subunit deficiency? Yes, it is completely deficient in your type 1A. There is partial deficiency in your type 1B, or even sometimes there may be no deficiency. Okay, this is the basic difference. Okay, fine. Now we will be looking at pseudo-hypoparathyroidism type 2 and pseudo-hypopara. Before we understand these two, let us look at the genetics of pseudo-hypoparathyroidism a little in detail, and then you will understand the rest. So first, let us look at the inheritance of these disorders. Okay, so first we will look at the normal inheritance pattern. So GS alpha subunit is inherited biallelically in the bone. Okay, so we know that the PTH action is predominantly on the bone and in the kidneys. So how is this happening? Let us see. So GS alpha subunit is inherited biallelically in the bone. That means what? This is the father, this is the mother, and this is your GS alpha subunit of the child. So this is inherited biallelically. That means both alleles should be present and should be functioning for your normal PTH action on the bone. Very clear? Both alleles from the parent has to be present for the normal PTH action on the bone, and so that you do not have your bone problems. So even if one allele is lost, you will have AHO phenotype. So if there is a defect which is inherited either from the father or from the mother, you will have an AHO phenotype. Is that very, very clear? But in the kidney, in the proximal convoluted tubules, what happens? Now if the PTH has to act on the kidney, what happens? In the kidney, due to unknown reasons, there is paternal silencing. This is the father, this is the mother. You get only your mother's allele of your GS alpha subunit inheritance. There is paternal silencing in the kidney. This is normal. This is not, I am not talking about your pathology of pseudo-hypoparathyroidism at all. This is normal. So whatever GS alpha subunit you are getting in the kidney for the action of PTH on the kidney, it is from the mother only. So GS alpha subunits in the kidney are only from the mother because there is paternal silencing, and this is a normal process. This is a normal process. So this is very, very clear. Let us just repeat it. So what are we looking at here? We are looking at the inheritance of your GS alpha subunit, and we are trying to understand why there are differences in your types of pseudo-hypoparathyroidism. So this occurs due to deficiency of GS alpha subunit, that we know. So the GS alpha subunit, depending on how it is inherited, its actions vary on the bone, its actions vary on the kidney. So the PTH action on the bone and PTH action on the kidney will be different depending upon what type of inheritance you have. So in the bone, if PTH has to act and if the bone has to be normal, then both the alleles which are obtained from both mother and father has to be functioning. In the kidney, normally itself, it is only the maternal gene that is inherited because the paternal gene undergoes silencing. Now let us look at how pseudo-hypoparathyroidism type 1 is different from your PPHP, which is your pseudo-hypopara. So in your pseudo-hypoparathyroidism type 1. So let us look at the genes here. So this is your father. The gene here is normal. Okay. So here, where is the defect? The defect is in the maternal gene. Okay. So where is the defect in pseudo-hypoparathyroidism type 1? It is in the maternal gene. Now this is at the level of the kidney. Okay. Let us understand at the level of the kidney. Okay. So at the level of the kidney, what happens? Normally itself there is paternal silencing. Your gene is going to be inherited from the mother only. Now the gene that is inherited from the mother is defective, right? So here, will you have the urinary response to PTH? Will you have the urinary response of CAMP or phosphate to PTH? Will the PTH be able to act? No, because you have got a defect from the mother. You got the defect. Generally itself, normally itself in the kidney, there is only one gene which is obtained from the mother. Paternal gene undergoes silencing. Paternal gene has undergone silencing. So you do not have a normal gene at all. You have inherited the defect from the mother, and hence you will not have urinary response to CAMP. Can you see there is no response? That means that the biochemical abnormalities will be present. Biochemical abnormalities will be present. So this is at the level of the kidney. In the bone, what happens? Irrespective of whether you get From your father or from your mother, if one allele is affected, you will have AHO phenotype, correct? So you will have AHO phenotype. Okay, so this is very clear about pseudo-hypoparathyroidism type 1. So here, as you can see, the defect is obtained from the maternal gene, and because it's obtained from the maternal gene in the kidney, you have the biochemical problems, and the paternal gene is silenced normally itself. So only the defective gene is inheritance and PTH resistance is there, and you will have an AHO phenotype. Now, in pseudo-hypoparathyroidism, focus very clearly in pseudo-hypoparathyroidism. Where is the defect? The defect is on the paternal gene. Okay, so in the bone there is a defect, right? So because either it is irrespective of whether you have got it from your dad or you have got it from your mom, if one gene is also affected, your bone is gone. So you will have Albright hereditary osteodystrophy. This is what we saw because it is biallelically inherited and it requires both alleles in the bone. Now because one gene is gone, you will have Albright hereditary osteodystrophy. But what happens in the kidney? What happens in the kidney? The defect is from the father, and normally itself at the level of kidney there is paternal silencing. That means that if your mother is okay, your kidney is okay. So if the defect from the mother is not obtained, it is obtained from the father, and that itself undergoes silencing. So the urinary response to PTH, so the PTH action at the level of the kidney is not affected. So phosphate excretion will be there. You will not have hyperphosphatemia. Clear? Very, very clear. So this is why it is called as pseudo-hypoparathyroidism, because they present with Albright hereditary osteodystrophy and you will say, oh, this is pseudo-hypoparathyroidism, but when you do the test, it is completely different. You do not have your elevated serum phosphate, you do not have your hypocalcemia, your urinary excretion is normal, urinary response is normal. This is the reason, because your defect is in the paternal gene and paternal gene is ultimately silenced in the kidneys. Okay, so in the kidney, the paternal gene is silent and the defect is not inherited. Therefore, there is no PTH resistance. This might seem very complicated, but if you see the video once or twice, you will get the hang of it. So let us just look at it again. So let us just look at table number 1 and table number 4, you will understand. So very, very clearly, pseudo-hypoparathyroidism has only Albright hereditary osteodystrophy. It does not have any of these biochemical parameters. So it has only Albright hereditary osteodystrophy and it does not have any of the biochemical parameters because the resistance is not at the kidney, it's only at the bone. And what is the genetic basis of that? We have understood. We have understood the concept of paternal silencing, and the defect is in the paternal gene, so it gets silenced ultimately in the kidney. In the bone, you require both the genes. Even if one is gone, you will have AHO phenotype. Okay. So this is how you differentiate your pseudo-hypoparathyroidism from your pseudo-hypoparathyroidism. Now, pseudo-hypoparathyroidism type 2, how is it different? So they also have these biochemical abnormalities, but what is the slight difference? What is the slight difference? Very importantly, they do not have the AHO phenotype. They do not have the AHO phenotype because the problem is not at the level of the bone. They do not have a GS alpha subunit deficiency. So there is no problem at the level of the bone. It's not an inherited, or it's not a problem with the GS alpha subunit inheritance. Here there is urinary response is there to CAMP, but the urinary response to phosphate alone is not there. Urinary response to phosphate alone is not there. That is a completely different cause altogether. Okay, so it is not that you have a GS alpha subunit deficiency. If you have that, then your bones also should show AHO phenotype. It's not so here. So that is about your pseudo-hypoparathyroidism type 2. Okay, so let us just repeat this once more just for your understanding. Okay, so pseudo-hypoparathyroidism is a condition where you will have symptoms similar to hypoparathyroidism. So decreased calcium, increased phosphorus, and what will you expect the PTH to be? Hypopara, so it should be low, but there is resistance to PTH action and hence PTH will be elevated. And this is what we are seeing here in type 1A and type 1B. How is type 1A and type 1B different? Because the amount of GS alpha subunit deficiency is slightly different. And both of them will have an AHO phenotype. Urinary response to phosphate will be blunted. In your pseudo hypoparathyroidism, there is no biochemical abnormality because the genetic defect is from the father and that gene gets silenced at the level of the kidneys, and hence there is no resistance to PTH action in the kidneys and you do not have any biochemical defect. But in the bones, you require both the genes to be functioning, and since the paternal gene is affected, there is paternal silencing, you will have AHO phenotype. So, though the normal gene is obtained from the mother, there is a defective gene inherited from the father. Only in the kidney it undergoes silencing, in the bone it is active, and hence because your bone requires a biallelic representation, here you will have an AHO phenotype. In your PHP type 2, you will have a problem only with your urinary response to phosphate, but all the other biochemical parameters will be present because there is a problem with the urinary response to phosphate, but you do not have an AHO phenotype because it's not because of a GS alpha subunit deficiency. Okay, clear? So this is about your pseudo hypoparathyroidism. Now, how do you manage hypocalcemia? So in acute conditions, how will you manage? You will have to give IV calcium. Usually it is given IV calcium gluconate. So it is given as 10 ml IV, 10 ml 10% IV over 10 minutes. Okay, 10 ml 10% IV over 10 minutes, and if there is no improvement, then you will have to start a calcium infusion. Whenever you start a calcium infusion, be very wary of high risk of arrhythmias, and hence you will have to put them on a cardiac monitor. Chronically, you may have to give them oral calcium at a dose of 2 to 4 grams per day. Activated vitamin D may also have to be supplemented because if there is resistance at the level of the kidney, you have to overcome it by giving calcitriol, right? PTH cannot act on the kidney, you have to overcome it by giving activated vitamin D. If there is magnesium deficiency, supplement with IV or oral magnesium as. So with this, we have come to the end of our chapter on parathyroid and parathormone disorders. We have looked at hyper and hypoparathyroidism. Thank you.